Welcome to AETCM, the emergency medicine channel. Shall I start?
Yeah.
Today I'll be presenting a case of a 62-year-old male who came with complaints of right cheek swelling extending up to neck associated with pain since 4 days. He had a left cheek swelling initially 6 days back, followed by which he had underwent left tooth extraction. He also had associated complaints of throat pain, odynophagia and mild breathlessness. He also complains of fever with chills since 2 days. On initial 10-second assessment, the patient was conscious, oriented and obeying commands. And on primary survey, airway was patent. There was no stridor, but there was a muffled kind of voice was there. And on breathing, air entry was bilaterally equal, but there are conductive sounds present bilaterally, and respiratory rate was around 22 per minute with saturation of 95% on room air. Circulation pulse rate was 128 per minute with a BP of 180 millimeters of mercury. CRT was 2 seconds, and coming to disability, the GCS was 15 out of 15, pupils equal and reactive to light, no focal neurologic deficits. Exposure temperature was 101 degree Fahrenheit. At this point of time, we had put 18 gauge IV cannula, and we had started on injection PCM 1 gram IV stat, and we had also started on fluids. IV fluid NS was started at 100 ml per hour. And
what
further,
was his pain score?
Pain score was around 7 out of 10. And coming to adjuncts of primary survey, his ECG showed a sinus tachycardia with ABG showing a pH of 7.409, PCO2 of 38 and PO2 of 78. Bicarb was 22.9, lactate of 2.4, creatinine was 1.21. Point of care, CBCRP showed total count of 7.4, CRP of 212. And coming to secondary survey,
ABG, nothing was abnormal, right?
No, nothing was. Only lactate was borderline, 2.4.
Okay.
Apart from that, it was fine. Creat was also 1.2. And coming to secondary survey, patient has no known allergy to any medications. He is on glimepiride and metformin for type 2 diabetes mellitus. And coming to secondary survey, the patient is a known case of type 2 diabetes mellitus who presented with, initially he had a complaints of 6 days back, a left side cheek swelling associated with the left tooth pain. And for this, he had underwent tooth extraction, and progressively the swelling decreased on left side. And after that, it had involved the right side of his cheek, and it was increasing in size but not resolving like the left side. And he also had associated on swallowing and all, he had painful swallowing, odynophagia was present, and he had slowly developed mild breathlessness since around 2 days. And also, he also noticed mild fever with chills since 2 days. There are no other complaints of any sounds, only he was having a mild hoarse voice. I said no other stridor-like sounds he was saying. And also, he was admitted initially in outside hospital around 4 days back, and he was treated with the injection augmentin clindamycin for 3 days for that left side cheek swelling. Now, because of persisting right cheek swelling, he had come to Amrita. On examination part, patient was conscious, oriented, no pallor, icterus, cyanosis, clubbing or lymphadenopathy or any pedal edema. Their local examination showed a gross swelling. It was extending from the preauricular region, and it extended down up to the submandibular region. It was almost consistency was almost induration was there and hard in consistency, and mild tenderness was present. Fluctuancy as such we couldn't elicit, and also there was a local temperature rise was there, and even laryngeal crepitus could be felt. Coming to the investigations.
So what was your diagnosis?
We are suspecting submandibular or sublingual space collection. We are suspecting. So most probably it can be Ludwigs angina.
Okay. So what is the cause of Ludwigs angina? What can be the
Ludwigs
organisms?
angina, mostly the most common organism, it is the oral, it is polymicrobial usually, and it will involve the oral flora. Usually it is Streptococcus viridans most commonly seen. And Other organisms can also, it can also include other anaerobic organisms such as Peptostreptococcus, then Fusobacterium or any bacteroides can be present. And also Staphylococcus aureus and MRSA can also be present in immunocompromised or children. It can be seen.
Okay.
And other causes, the mandibular second or third molar tooth infection can also involve the submandibular space.
So the primary infection can either be from the submaxillary area, sublingual, submental or submandibular region. So if it is mostly in the medial infection, it can be because of the infection of the anterior tooth and also in such cases infection will be in the submental area, and in the molar infections it will be in the submandibular area.
And also, if there is any parotitis, suppurative parotitis, it can involve, or any peritonsillar abscess can also extend into the space.
These are the other sources
of infection.
Ludwigs angina. And what is the most dangerous part of Ludwigs angina?
Ludwigs angina for us, as ears perspective, will have a airway compromise because of the increasing swelling and all. And if it involves the parapharyngeal space, mostly the airway trachea will be narrowed. Narrowing of trachea will be there.
And narrowing of trachea, and patient might have trismus also. Mouth opening will be
restricted.
Okay. So symptom wise, what all symptoms will you expect?
Usually fever will be present, and mouth or local region pain will be present. And also initially trismus won't be present, but later on trismus muscle contractions, tetanic contractions can be present.
Hot potato voice, throat pain will be there.
Voice will be present.
And later on only trismus. Trismus will be coming if there is any parapharyngeal space involvement. This hot potato voice and all because of what? Because this swelling over this area will push the tongue up, and the tongue will start getting swollen, and it will start obstructing the airway. Along with that, that we can see that when we are opening the mouth, we will be able to see that big tongue. Similarly, posterior aspect of the tongue also, that swelling will be there. That is what is causing the airway obstruction. Okay, this can cause the voice change.
Then coming to investigations. We have done a CBC lab-wise, showed a same total count of 7.42, and CRP was elevated to 220. And also creatinine was borderline 1.3. Creatinine was present. LFTs were normal. Sodium, potassium, everything was normal. Procalcitonin was 1.17. INR was 1.36. Apart from that, rest of the lab was normal. And we also did a emergency MDCT neck with contrast. And initially, before that, we had initially done the USG of the neck, and neck has been done to look for the any tracheal narrowing is there or not. So minimal tracheal narrowing was suspected, so we had planned for the emergency MDCT with.
Which is better, CT or MRI?
CT is better. It is quicker, and also even if we are suspecting an abscess only, we require MRI.
So actually Ludwigs angina will not have any abscess. It will be generalized edema. It will be like a cellulitis, necrotizing fasciitis like picture. It will be generalized. There will not be any collection as such, and it will be mostly involving both the sides. It will be having a bilateral appearance.
In MDCT neck, which we took, it showed multiple abscesses involving the bilateral submandibular and submental spaces, with involvement of deep cervical spaces, and also involvement of the retropharyngeal and prevertebral spaces was there. And also there's a collection involving the left paraglottic space, which was causing the mild luminal narrowing. Around the diameter of was around at this narrowing site, it was 5 millimeter diameter. And we had called ENT consultation for the same, and they had planned for the incision and drainage of that submandibular abscess. After that,
so before the surgical management, what all antibiotic was started?
Patient initially, because of the lactate on borderline and BP on lower side, tachycardia, we had started him on IV fluids, around 1 pint bolus, and then 100 ml per hour was started. Then we had started on antibiotic high dose injection Piptas, 4.5 gram IV TID was given, and along with that anaerobic coverage also was given, metronidazole 500 mg.
When will you give this antibiotic Piptas, and all? Is the patient immunocompromised, diabetic or something?
Patient type 2 DM is
Yes,
it?
sir. So
Diabetic.
immunocompromised individuals, we'll have to plan on higher antibiotics like
Antibiotics.
Piptas or meropenem. Okay.
And then metronidazole was also given, 500 mg IV TID was given. And further, we had planned for intubation in operation theatre.
So what all antibiotics will you consider depending on the patients? If it is immunocompetent patient, what will you start?
Immunocompetent patient, we can initially start on ceftriaxone, 2 gram IV BD, or and
Ideal
along
dose
with
is 1 to 2
metronidazole,
gram.
1 to 2 gram.
Ceftriaxone with metronidazole,
Metronidazole
or
can be given, or if they are resistant to this penicillins and all, if they are allergic to penicillins, then we can start on levoflox.
so first
500
line we
mg
can
OD or
always consider it as this thing. If the patient is sensitive, immunocompetent and sensitive to penicillin, you can always start ampicillin sulbactam. That is only required. That can be given every 6th hourly. Then if the or you can start as a combination of ceftriaxone or metronidazole. Ceftriaxone with metronidazole combination. And if the patient is having allergy or penicillin sensitivity, allergy or resistance is there, then we can plan on considering levofloxacin. And that also 8 to 10 mg per kg BD dose can be given. And if the patient is having MRSA, then what will you give?
For MRSA suspecting patients, we will have to add vancomycin based on renal status. Creatinine is normal, we can start on vancomycin. And based on the creatinine, we have to decide the dose. Usually 1 gram BD or TID will be the dosing. And
so 10 to 15 mg per kg. And linezolid?
Linezolid we will be giving 600 mg IV
twice a day.
Twice a day.
And that is in case of an immunocompetent patient. Competent patient.
Competent patient with MRSA.
If the patient is immunocompromised, then we'll have to give, as you told, Piptas and anaerobic coverage if there is no coverage. And or you can, so Piptas you told, meropenem you have told, then or we can give cefepime with metronidazole. And we'll have to add MRSA coverage also. Okay. Then regarding airway, if the patient is having airway compromise, what will you plan?
If airway compromise is there, we have to do early intubation is needed. So we have to ideally do a fiber optic intubation. That also ideally nasal route should be used. And with the view only, we should ideally do such intubations, because if we
so in the long fiber optic tube, we will have to put the ET tube inside. We will have to visualize the inside area, and then only you need to railroad within the fiber optic laryngoscope.
So if there is diffuse edema, everything is there, then we do blind intubation. It can cause laryngospasm. So that should be avoided ideally, and we should opt for the fiber optic intubation. And also tracheostomy or surgical airway kit should be made ready along with this. So ideally, the intubation should be happening in an operation theatre ideally. And further, the patients, we had also sent the collection. We had sent for culture and sensitivity. It showed Candida tropicalis, scanty growth only it was shown, and also fluconazole 400 mg OD was started for 14 days.
Okay. Any other gram positive or gram
negative?
negative?
No gram positive organisms are shown.
Maybe we have already started the antibiotic prior to that.
Already
maybe.
Outside hospital, he was being treated with antibiotic.
That's why we didn't get the organism. Okay.
And then the incision and drainage was done. After that, actually, the CRP everything was down trending, and after some time, they had repeated the MDCT, which again showed multiple. It showed diffuse edema in the right masseter space and buccal space with ulceration on right cheek, and underlying multiple collections. Representing features of cellulitis was seen, and also the prior documented collections with small residual collections and all was seen. Multiple collections in multiple spaces, submandibular, submental, prevertebral space has increased in size. So again, they had planned for a repeat incision drainage of retropharyngeal abscess was done. Even the parapharyngeal space was also opened and abscess was drained. And after that, corrugated drain was kept passing through and connecting all the incisions. After that, The patient eventually improved, and the patient was then extubated, and he was vitally stable.
Okay. So what if this patient goes into respiratory arrest or becomes tachypneic in the ER? If there is an airway compromise in the ER and you tried intubation and it has been failed, what will you try next?
You have to do surgical airway, has to be done, tracheostomy.
So tracheostomy is
Or
not the
needle
surgical
cryo.
airway. Tracheostomy
needle
we usually
cryo.
plan after while we are weaning from our ET2. If the patient requires prolonged ventilation, then we will plan on tracheostomy. In ER, surgical airway is always
Needle cryotherotomy.
and surgical. So how will you plan on doing needle?
Needle cryotherotomy will locate the cricothyroid membrane will be located, and after cleaning and
how will you locate?
You have to palpate from the thyroid cartilage and the lower.
The most prominent thing will be the thyroid cartilage.
And below we'll trace the finger up to the prominent portion, that will be cricoid cartilage. So the cricothyroid membrane will be taken as a spot, and we'll clean and drape the area and give a local anesthesia will be given with lignocaine. And after that we'll have to take that needle cricothyrotomy. Either we have to do blind procedure as we done, or we can use with the help of a fiber optic. We can with the aid of fiber optic we can do the
also.
can be used after.
So what size needle will you take?
18, 16.
14 or 16. 14 size IV cannula or a needle. Ideally a needle with the hub, or better to take a cannula, 14 to 16 size cannula.
And we'll attach the end of syringe. If you're doing blinded, we'll have to insert and then check for air bubbles coming into the saline.
So we need to take some saline in a 2cc syringe and attach to it. And one person should introduce. One person or the person who is doing the procedure should hold the trachea with the non-dominant hand, and other person should and with the dominant hand we need to prick it. What direction? Upward direction,
downward direction.
30-degree caudally. You will have to prick downwards, and then check for air bubbling. If air bubbling is there,
then we are in the space, and we can then remove the syringe and put the Seldinger's technique we can use.
For this is just needle cricothyrotomy. So in this patients, after getting into the trachea, then we can give jet ventilation. Jet ventilation with 30 to 50 psi pressure, you can start jet ventilating the patient, and that can be jet ventilation can be done up to only 30 to 45 minutes. Within that time we need a definitive airway, that means a surgical cricothyrotomy. So either in the OT or in the ER itself. So how will you plan on doing surgical cric?
Now after that we'll have to introduce a guide wire into the and
either with the guide wire, Seldinger's technique we can dilate,
and then we'll dilate dilator for the insertion of the tube, and after dilating adequately we'll introduce the original tracheostomy tube will be introduced.
Surgically, how will you open?
Surgically you have to make an incision.
First we'll have to hold with the non-dominant hand and make a incision? Vertical incision. Vertical incision in the cricothyroid membrane. Open, then vertical incision on the skin. Then when you reach the cricothyroid membrane, make a horizontal incision. And insert once airway is open, we will see the bubbling. Then insert a bougie through it, and then insert a ET tube. ET tube, we can select either a 5 size or a 6 size ET tube and insert so that only the cuff is going in. Okay, otherwise if you are going too much in, we will be going into the right bronchus. Or a tracheostomy tube, 5 or 6 size tracheostomy tube can be inserted. And we will have to check for the ETCO2 and bag and mask can be done. Okay. So this patient airway for the initial surgery, intubation was done. And a procedure was done. Post that CT was showing collection and that was also drained.
Drained again.
And how was the patient?
Then he improved, extubated, and he was vitally stable.
Okay.
Swelling, everything is reduced. Counts also got low, reduced gradually.
Okay. Thank you.